First, thank you, Alaji Oncology Now, for inviting me. It's been a pleasure. Terrific platform. To answer your question, so despite the recent huge advancements and developments in the management of metastatic urothelial carcinoma, there are still a lot of unmet therapeutic needs in the rare histologic variants in bladder cancer as well as other cancers of the urinary tract. Our research interest as a group has been focused on small cell bladder cancer, falling under the umbrella of small cell neuroendocrine carcinomas of the urinary tract. So this is a disease with very dismal prognosis and a lot of unmet therapeutic needs. For example, around 10 to 40% of patients only survive beyond 5 years. So there is a lot of space to do over here as well. Recently, we have published our series in favor of a standard of care in the treatment of localized small cell neuroendocrine carcinomas of the urinary tract. And that consists of neoadjuvant chemotherapy that targets the small cell regimen followed by surgery. And in our series, we found that the chemotherapy that target the small cell component, like etoposide plus cisplatin EP, or alternating regimens of etoposide cisplatin EP with IA, ifosfonide, adriamycin, gives a benefit in pathological downstaging as well as overall survival. So right now, we're trying to understand the biology of this disease because a lot remains unknown. And despite our current knowledge, our building knowledge in the neoadjuvant space in the localized setting, we still don't know what happens in the post-surgical outcomes or what's able to predict the metastatic relapse risk. Data was extracted from a historical institutional database of around 224 patients with small cell neuroendocrine carcinomas of the urinary tract treated at MD Anderson between 1985 and 2021. And of course, because of the rarity of this disease, it is very hard to enroll these patients in randomized clinical trials. So this is our best way to try to evaluate our experience and try to make inferences out of it. So we were interested into analyzing the metastatic relapse outcomes, which were analyzed as time to event outcomes using a competing risk approach. And then we used the cumulative incidence functions method to try to analyze these outcomes and try to see which variables are most associated with metastatic relapse. Regarding our results, we found that a metastatic relapse incidence of around 41% in the entire cohort. However, we also wanted to look at the specific impact of the morphologies or the histologies at resection and their impact on the metastatic relapse risk. For example, among patients who had specimens showing PCR, we found that patients who had PCR after neoadjuvant chemotherapy had the lowest cumulative incidence risk, and that which consisted of around like 16%. However, for example, patients who had PCR after TUR had a lower cumulative incidence, which means a higher metastatic relapse risk of around like 71%. However, there's also a subset of patients who have specimens showing residual disease. Now, before saying about the cumulative incidence and telling about the results, we must define these histological outcomes. So among residual disease, we have possible minority small cell, which means a small cell that occupies less than 50% of the surgical specimen. We also have predominant small cell, which means where the pathologists see a small cell component that occupies more than 50% of the specimen. And we also have specimens that only have exclusive small cell. And of course, these different outcomes are affected by the neoadjuvant chemotherapy, which exerts some pressure on eradicating the small cell and, of course, and the different outcomes. So, regarding the results, we found that patients who had minority small cell had the lowest risk among those who had residual disease, and the risk was kind of increasing progressively with the increasing contribution of small cell. So, by increasing from minority small cell to predominant small cell to exclusive small cell, the risk of relapse was increasing. And this is very interesting to see because this will also probably may influence other therapeutic strategies, as we will talk after. So using these cumulative incidence functions, we were able to do a multivariate analysis to try to see which outcomes are associated with the metastatic relapse outcomes. So of course, we found that histology at resection is a major affecting factor. We also found that staging at diagnosis and staging also at surgery are other factors which we also expected to influence the metastatic relapse outcomes. Now, the morphology or the histology at the resection is a novel aspect because, of course, as we know, most studies in urothelial carcinoma, they focus on the impact on the disease burden, right, at the stage of diagnosis and at the stage of surgery. But this study was kind of first to show that even when we account for the effect of neoadjuvant chemotherapy and stage at diagnosis and surgical rejection, there is still an impact of histology at resection on the metastatic relapse outcomes. So as you can see, like these days are very exciting. We're kind of seeing some exciting data about the role of adjuvant immunotherapy with like adjuvant pembrolizumab showing at least a disease-free survival benefit, like in the Ambassador trial, which was presented at GU ASCO. Also, we're seeing some other data on adjuvant nivolumab. So we're kind of seeing some increased data in urothelial carcinoma. However, for small cell, we first need to understand the biology of the disease and its behavior, and to understand which component drives the metastatic relapse before we define current approaches. So currently, these findings, at least, they kind of orient to new studies that can possibly, like adjuvant approaches, depending on the residual cancer that is staying at the specimen. So probably we can orient these approaches at the residual small cell to prevent the metastatic relapse, which appears to be driven by this component. I would just like to give a highlight to the GU Oncology Now. Make sure to follow them if you're not following them, and thank you for inviting me again.